Hi everyone, this is Shauna Strickland. Welcome to Healthcare Changes Made Public, Now What? This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013. My name is Shauna Strickland, and I'm your moderator for today. Rick Ford is our presenter. He is the Director for Respiratory Services at the University of California in San Diego. And now I will turn it over to Rick.
All right, thanks, Shauna. It looks like my audio is coming through, so I'll assume everyone can hear me. And thanks for asking me to do this. You know, I, like many of you, I was a revenue manager for a while there. That was pre-1983 when we actually charged for items and got paid for them. And then along about that time, DRGs came in, and since that time, I haven't paid any attention to charges, maybe a little bit, but I've been a cost manager, as all of you have been. So when the federal government released some of what they call prices, we kind of got, uh-oh, what are those things about? And I did the same thing. And so what we're going to do today is just conduct a brief session on what this is about. And you may know more about this than I do, so I encourage you to type in questions or even feel free to answer someone's questions that's posted, because we may have some pretty interesting questions and dialogue at the end of this. But in any case, let's jump right in. Well, what happened that first, second week of May is the federal government decided it was going to release prices. Okay, and whether it was politically motivated or not, we're obviously not here to talk politics, but when you start reading the Huffington Post, the Washington Post, you'll see that there's some political overtones in terms of maybe the administration trying to defer the public's attention and to the real issues with healthcare. But we're not here to talk about that. We're here to talk about the data and what it means to you. So really, until now, hospital charges have been closely held by facilities, meaning, you know, they haven't shared them. In some sense, that's a competitive advantage. In some cases, it's because the charges just frankly don't make sense, and they didn't want to put out data, willingly put out data that doesn't make a lot of sense. And what the numbers reveal is basically a healthcare system with tremendously and seemingly random variation in the cost of services. Now, we're going to clarify something here. It's very, very important, because in some of the articles, in fact, many of the articles in the Washington Post, even in the data that's on CMS website, they refer to cost. And you and I know that there's a difference between cost and charges. And really, what these are, they're all about charges and not necessarily cost, and we're going to clarify that to an even greater degree. So why did they release them now? Again, there may be some political reasons, but Jonathan Blum, who is the administrator over CMS, has stated that the public release of this data is part of an effort by Medicare to increase transparency in the healthcare system, and actually announced that there's a slight change in their mission. To be a trusted source of marketplace information. So this is kind of a brand new role for CMS to play, and they want to provide clarity and transparency on charge data. So that's why they were, officially, that's why they were released. So if you want to get to this data, certainly the AARC has some sections on the website where this issue is addressed, and they have a link. I think Shauna sent the link out as well. But if you go to cms.gov and just in the search, you put Medicare provider charge data, you're going to come up to this particular page, which is the introduction to the charge data. Now, I didn't cut the entire screen out to put it on the slide, but below these few paragraphs are several links, and those links will allow you to download an Excel file or a CVS file. It will allow you to download either the entire national database or it will allow you just to download for your state. So if you really want to take a look at this data, we're going to just look at it briefly, but you'll want to download that file. I will caution you, it's a 13 meg file, so it takes a while to download. And if you're the victim of an old computer in your hospital, it does take a while to open and does take a while to manipulate because the database is so large and the functions embedded within the database also consume some of your computer's resources. So be prepared to stare at your screen a while this thing loads. But I'll make it easy for you. We've got a couple of screenshots of the data. You'll start out with a couple of pages that are embedded in the Excel that tell you a little bit about the data. These are tabs that are on the Excel spreadsheet that will basically tell you what the study population is. Of course, the 50 states, they essentially took the top 100 DRGs. So they look at everything they're paying for of all states, all hospitals. They took the top 100 and then applied those 100 to your state. So it's not the top 100 in your state. It's the top 100 nationally applied to your state in fiscal year 2011. Okay. And what they're doing is they're providing what they call the average total covered charges. That's just a fancy word for what the hospital charges, the price of the hospital's charging for that, those services, and then the average total payment through CMS, which consists of a variety of elements. Okay, and then it's going to have the numbers of discharges. Now, I'll share with you that I was very interested in this data because I can't get this data from my own hospital. You know, when you look at, you know, I've often said, okay, what are we getting paid for that case? And it's not easy information to get to, but do know that you can use this database to get to that information and to look, for example, the number of discharges for a aortic valve replacement versus a joint replacement. And so you can look at the number of discharges from your particular hospital and have data at your fingertips so you can see what slice of the pie you own. You can also see what the hospital gets paid for it, and so perhaps what you're contributing in terms of the hospital's overall payment. This defines the fields that are in the database. Of course, we know what a DRG is. The average covered charges, as we talked about, are the prices, and the total payments are the payments that are provided by the feds. And it's a complex equation. We'll talk about this a little bit more, but it includes the disproportionate share, teaching, capital outlier payments, basically everything that's being paid. So let's take a look at the data. You won't be able to see a lot on this slide because I just wanted you to have a concept of what the database looks like. And I will tell you, this is really, they did a nice job of providing this data. You've got for example, the DRG definition there. What you have is you have these arrows that allow you to not only sort the data, but to specify what you want displayed. So if, for example, if I just wanted to see let's say pulmonary embolism number 176, DRG 176, I could click on this arrow and it would allow me to select if that's all I want to see or what groups of procedures you want to see. So all these columns in the Excel spreadsheet provide the ability not only to sort but to select exactly what you want to see. And I chose not to do that on the live Excel spreadsheet because it's a big database and I have an older computer and we'd be here forever waiting for it to update. But it is really nice how they've laid this out. You can select your particular hospital, just look at that. You can select a couple of comparative hospitals. So they've made it easy for us to sort through this huge database. We'll just cut to a couple of, cut out some of the screens so we could talk about them a little more. Again, the DRG definition, so we not only have the DRG number, but the definition. This happens to be the provider ID. When you download the database, it's going to be sorted by these provider IDs. So that's the ranking by which they are sorted. And then it's going to have the hospital. We're just going to cut straight across. aligned with these fields would be the total number of discharges. So like I said, if you're wondering how many discharges you have for COPD or pneumonia or pulmonary embolism or some type of heart surgery, you can actually look through here and see what your total discharges are. And again, kind of see what percentage of the pie, the types of patients that are in your hospital that you're involved in. Again, we've got the average covered charges, which are the total average payment for those 91 discharges. And then I slipped there. It's real easy to slip. The charges that are issued by the hospital, and then the payments that are actually provided. Now, you're just looking at this first set of data going, oh my gosh, look at those disparities. There's not only disparities in terms of the charges, but in what's paid, which we know, but there's tremendous disparity between hospitals. And rather than going through the database, we'll just show you a couple of examples. These are out of Florida, and hospitals essentially right across the street from each other, the cost for heart attack with stents, the average charge in one of the hospitals is $166,000. The average charge to the patient in the other hospital is $89,000. A tremendous difference in what the hospitals are charging. The average reimbursement is also different. Okay. And there's a whole new set of rules for reimbursement that the feds apply. Are there any set of rules for what the hospital charges? Actually not. About the closest you're going to find in the set of rules, if you have a research division, they may say that you calculate out your direct variable cost and add 60% for overhead. So I get explicit instructions when I'm setting charges for research rates. But when we're looking at charges for procedures, we really don't have any guidelines, and the hospital doesn't apply any. Well, they probably apply some guidelines, and I'll share with you some of the things we do. But there are no regulations or limits or reason behind what the hospital actually decides to charge the patient. So this is what got the public's attention, and this is what kind of got things kind of started talking about through the ARC. So what about respiratory charges? If we do look at some of the respiratory diagnoses, this is a ventilator bill. In one hospital, ventilator bill was $115K. The other hospital was $53K. Now, right away, you should be thinking that, okay, there are differences in ventilator patients in terms of what they receive in addition to ventilators. But again, the public isn't made aware of those things. The public is also not made aware of outcome data, quality data, safety data, customer satisfaction data, those types of things. Certainly we can find those in other places, but you know, those are reasons why we've got some differentiation in charges too. Treating a simple case of pneumonia. So this is pretty simple pneumonia. One place in Philadelphia, $124K, and in Mississippi, this is where you want to go, I guess, if you got a pneumonia, they only have $5,000 worth of charges. Okay, so again, another example in New York City, two hospitals, 63 blocks apart. They varied 321% just in treating asthma or bronchitis. And this is all in the Washington Post if you want to go and check out that article. So also in that Washington Post, if you want to kind of look at things particular to your hospital, they have a little selection calculator. And what you can do is you can put in your particular state here, and then it will pull up the lowest price in your state, the highest price in your state, and the national average. So you can kind of see the ranges. Now the public was obviously clicking on this too and commenting, and reporters were, that there are these huge disparities in hospital pricing. Another closer look, particularly with COPD, is this, I believe, is in the New York area, and what they did is they took the price, the charge for treating COPD in all these hospitals and posted it. You'll see great variability. The lowest price, the lowest charge for treating a COPD admission was $7,000, and the highest was $99,000. So with these articles that are being published in magazines, in the press, they really seem to be focusing on the price hospitals are charging, and to some degree demonizing hospitals and diverting the attention from the whole reimbursement issue in what hospitals are actually getting paid by the federal government. Okay, so let's clarify something as we did at the very beginning, is that again, in all this stuff we're reading, it talks about cost. These are not cost. These are charges, just as if you were to go into Target and see what they were going to charge you for a big screen TV. And the other piece is what's getting paid, the cash that is exchanging hands from the federal government to the suppliers. I also want to draw your attention that you guys know that if you go to any place and you see a list price, what do you typically do? We've all got iPhones or something like that, and we're pulling out red laser. We're seeing what others charge for it, and we're going to go buy from the best. We're also taking into account service, customer service, repair service, all those types of things. And with the release of this data, we may see some more of that happening with healthcare, because there are some implications for consumers if we have different pricing. Again, don't try to read the numbers on this particular chart. This was a summation that was done off the national database that talked about each state in to what percent they were overcharging. This means that if they were getting paid, let's put this in simple terms, $100 from the federal government, what were they charging to get that $100? And in Vermont, they were charging 67% more. So they were charging $167. They'd get $100 back. So that's one end of the scale. The other end of the scale is New Jersey, where if they were getting $100 back from the feds, they were charging $523. Okay. And so as health consumers may look at this and they may say, okay, I want to do business with one of these hospitals if I've got to pay a portion of the bill. So you're going to find that variability in your state as well. So that's, again, the source of this data is, this is actually, I believe this is coming out of the Washington Post articles. So, okay. Again, we get back to charge versus payment because that's what it's about. And keep in mind that hospitals determine what they charge, and they amount to what is being billed to the patient. Total payment includes the MSDRG and all those things that go into that particular payment. We're going to talk about these just a little more. So why the difference in charges? And experts attribute it simply to health systems can set those prices with impunity because consumers didn't see them, no one else seen them. And what they're doing, as you know, they're cost shifting. And I'm going to share just a little bit of specifics on the RT charges. And I think it's also important that as we're talking to the public, that it's imperative that what a hospital charges Medicare and the federal government is really completely unrelated to how much they're reimbursed. They're two totally different systems that are really somewhat unrelated. So, and you guys know that what we manage is the charge master. So, and the reality is, the opinion of some is the charge master is complete nonsense. My personal opinion, that's my opinion as well. And I didn't pay a lot of attention to my charge master since 1983. You know, and really, unless you're an uninsured person or you're picking up a portion of the non-covered charges, it's going to impact you. Okay, and again, some will say, you know, the biggest irony of this is it's the people that can't pay that have to pay the full amount. But the reality is really no one even pays that full amount, and you may know of, you have a financial counseling department, and they do all types of things. They'll put charges. There's an entirely different charge system that's like based on family outcome. There's shared liability with the payers. There's self-pay discounts. There's cash discounts up to 30–45% that these patients can take advantage of. So it's not nearly as bad as it sounds. Okay, so let's just look at a charge master. This happens to be my procedure list, and we worked with a consulting firm to look at the pricing across Southern California. And so what I'll draw your attention to is, let's just look at BiPAP. So we charge BiPAP initial day, and we charge subsequent day. And when we looked at what hospitals around Southern California were charging for BiPAP, the very minimum was $319. And then if you were in the 10th percentile, it was $478, and it works all the way up here to the max. Someone was actually charging $4,159 for BiPAP. And so this was an analysis that was done for us, and the question is, okay, if someone's charging $319 and someone else is charging $4,159, where does UCSD want to position itself? And this year, the hospital engaged me in these discussions, and so I made sure that I understood what it cost us to begin with, because we've got to recover our cost, and that we were somewhat reasonable for hospitals in San Diego County. I had another set for San Diego County as well. And if you glance through that, you can see it doesn't matter if it's an ultrasonic aerosol treatment or looking at even an aerosol treatment evaluation, the difference in pricing. So it really is remarkable when you look at the difference. Now what the hospital does to figure out changes in pricing, this is how crazy it actually is. I want to take you through this. This happens to be some data from my charge master. I hid the procedures. But what the hospital was proposing is a 25% increase in this particular procedure, a 61% increase in this procedure, a 170% increase in this procedure. And then what they did is they looked at the impact on outpatient and they looked at the impact on inpatient. So the gross charges, if we would increase this particular procedure by 170%, let's go down to this one, this procedure by 170%, it would gross $47,988. That's how much it's going to gross. It's not an outpatient procedure, so there's nothing coming in on the outpatient. Okay, so the total gross impact is about $48,000. And then we looked at what we collect. Although we would increase the charge by $47,000, that increase in charge would only result in an increase in net revenue of $1,345. And so what the hospital is doing is they're looking at where can they maximize their net revenue and how much they have to crank this number up over here. And that's how they come up with some of the charges that you're seeing on your charge description master. And what I have gone is I've gone and said, you know, I think this is absolutely absurd and rendered my own personal opinion for what it counts. But that gives you an idea. It's just a numbers game, and it really doesn't make a whole lot of sense. So we've talked about the pricing piece of it. Let's just talk briefly about the payment for care piece and what DRGs are about. And it's kind of like a black box. The government pays X amount, and how they get there is very difficult to understand. It's based on some complex formulas that are too hard to explain, but they take a variety of things into account. And what I did is I just cut a small section of a DRG calculator. And this is for, I believe this is actually for the state of Illinois. So this is some of the calculations that are gone through and some of the tables that have to be referenced to come up with the DRG price. It really is confusing, and that would explain how come one place is getting reimbursed $67,000 for a 5-day heart patient, and the other place is getting paid $38,000 from the government. There are disparities because when the government puts these equations in motion, it's going to result in a different DRG price. And so that's why there are such disparities. By the way, this is only the first page. This goes on. You get the DRG price, and then there's a ton of adjustments to that as well. So that would explain the differences in what we get paid. So let's just sum this up with some general implications. I think the data sheds light on fees that the uninsured could pay. Our private insurance companies, where the consumer pays a proportion. So consumers have to be a little bit smarter. I think hospitals are going to react to this by being a little bit more reasonable in where they place their charges, and they may actually start to be competitive. Also keep in mind that the uninsured rarely, if ever, pays that price, because if they go through patient financial counseling, there's always a discount, and there are programs related to weighing those charges based on income. Okay? And again, other implication, the bills that hospitals submit to Medicare have little relationship to the amount that the government actually pays. And as we could see, that sometimes the hospital give a larger bill to Medicare, but they'll get paid a lesser price. So, you know, there's no connect between those two. The other thing is, as we're talking with the public, is that the hospital charges in the variation, the actual hospital charges, when they're looking at those extreme variations, from a taxpayer standpoint, do not cost the taxpayer a dime. Okay, that Medicare budget stays where it is. The regulators and the feds decide, you know, how those DRG equations are going to be formulated and what the hospital is getting paid. But the actual charges by the hospital, it's perhaps the average taxpayer should not get too upset with those because it doesn't impact them. Okay, let's talk about implications for RC managers. It is important that you understand your cost per service, because if you get engaged in setting prices in your charge description master, you first have to make sure you know what it costs you to deliver a service. This year we were actually working with setting charges in our PFT lab, and there was such a narrow margin, we felt that it would barely cover our cost after overhead was added in. So we actually increased the price of our incremental exercise test. But you've got to understand the labor components and the supply components, so you understand your cost first. Own that charge description master. If you were like me since 1983, you may not have paid a lot of attention to it, but it is important we pay attention to it. Perhaps we can talk some reason into our patient finance departments and minimize some of this variability that's getting attention. Particularly, I mean, you could see that one section of my charge description master where we're going to increase a charge by 170%, and the net income to the department was going to be about $1,500 a year. I mean, so why are we making the change? So we may be able to talk some sense into some of our finance folks. The other thing is never benchmark against gross revenue. And when we're looking at Solucent, Premier, and some of these benchmarking companies, they will actually use revenue as a metric to benchmark your department by. For example, hours per revenue. Those types of things. And you can see that revenue number is all over the place. And so whether they're benchmarking you against what the government's paying or what the hospital charges are, I think you have a pretty good argument for them to use another metric. Also, don't use the charge data, and this is what the hospital is charging in comparative research. And some of you out there probably participated in reviewing some journals for reviewing articles for the respiratory journal, or even maybe reviewing some abstracts, and I've noticed a lot of hospitals will use what they charge to talk about how they decrease cost. And this is just to clarify, we don't want to do that. But I think you know, some other general uses for RT managers, as we've talked about, you can get a good picture of your patient mix and how and what piece of the pie you have, and how much you own. And you may be able to do a better job of actually sharing with the administrator how you contribute to them making money and getting reimbursed in these particular areas. And you could actually quantify, for example, if COPDs are readmitted, what type of hit that's going to take, and perhaps how you can play a role. So those are some of my thoughts. Again, not an expert, but I was glad to share some opinions. And I think that was my last slide. Yeah. So we're open to questions. You guys may be able to answer your own questions, but if I can do it, I'll try. So thank you all, and that's it for the formal presentation.
Well, Rick, we absolutely appreciate your time and going over this, and I thought I had a fairly good grasp of what was going on with this document, and now I realize I need to go back and do a little bit more investigation myself. So a couple of comments and then a question. One of the participants commented that at the beginning of your presentation, granted it was just one example, but it almost appears as if you charge less, the less you charge, the more revenue you could get. Is there any correlation to that?
In many cases, that's been noted. And certainly that first example where I think we were looking at 2 hospitals in Florida, that was exactly the case. And that's the article in the Washington Post draws attention to that. But if you really do look through the database, you're going to find they're all over the place, and that they really have no correlation with each other. But that observation was duly noted, and again, I think they talk about that a little bit in that Washington Post article.
Another participant made the comment that what a lot of people, and I'm going to the public here, what a lot of the public might not realize as they're looking out at these maps that these media outlets have prepared of different charges and stuff, is that they may not be taking into account cost of living and different kinds of things in each of those areas. I don't know if that goes into the mix as far as revenue goes as well, or charges rather, charges go.
Well, I think that's a good point, Shauna, is that we've got to keep in mind these numbers are what they are. And again, they're based on some complex formulas in terms of what is reimbursed by the feds. And in terms of what the hospital is charging, they aren't based on any complex formulas. They're based on a consultant probably coming in and trying to maximize a hospital's revenue by seeing what they'll net off certain things. But those are presented in isolation. And again, we talked about, I mean, there's a variety of factors that have to do with, cost of living in that community. There are even more factors that are, as a consumer, that I'm more concerned about. For example, the outcome of the hospital, the quality ratings, the safety ratings, the customer satisfaction, which we can all get through health grades and other databases. And so none of that's taken into account. And it's important for healthcare consumers and for us to advise them that you have to look at these other pieces. And perhaps in time, now that this data is out, people will start combining these databases, and hospitals will certainly perhaps do a better job of sharing other information.
One of the participants seemed to have a question that confused me as well. As we look at the cost matrix that you had shared with us, it's interesting to see the logic of, if I increase the charge, then all of these providers with a fixed reimbursement statement or system will actually increase the amount that they pay us. How does that work? How can we actually increase the amount that these folks will pay us simply by increasing a charge? Right on the prior screen, the blue one.
Yeah, yeah, and that is just a game of nonsense as far as I'm concerned, because if you look at this particular screen, it really doesn't matter if I am charging $319 for a BiPAP, or if I am charging $4,159 for a BiPAP, taking into account our case mix and our method of reimbursement, it makes absolutely no difference. And in that one slide we talked about here, when we look at, I'm going to increase a charge of this particular item 170%, which will bring me $47,000, $48,000 of gross revenue. But when I look at what I'll collect off that, it's only $1,300. So it's just a crazy game being played. Now, where am I getting that $1,300 from? I'm getting that perhaps from the 5% cash payers, and they aren't even paying. If I was charging $4,000 for a BiPAP, I guarantee you they aren't paying $4,000 for a day of BiPAP. they're negotiating it down 30 to 40% as cash payer. So I think what the data has just done is just brought this discussion to light, that there is a disconnect between what hospitals charge, what their pricing is, and what the federal government pays. And there is a disconnect amongst hospitals in terms of what they're pricing for the same items. So we may see, again, we may see some changes, but it's important for us as a respiratory community to understand exactly what that database is about, how it impacts us, and how we may be able to influence some changes in the system.
Thank you very much, Rick. I'm reading a couple of questions here. We've got some really good information. Someone asked if you could share the citation for the Washington Post and the Huffington Post articles. I actually, for those of you who are interested in those, we'll hunt down those citations, and when we post the archive, we'll post those links to those citations as well. So we'll get that out to you as well.
Yeah, and also, Shauna, that's good you're putting those out. The other thing is that is if people just do a Google hit, I mean, the one calculator I had where you put in your state and it tells you the high and the low and the medium. I mean, if you just put in, hospital charges, Washington Post, you're going to get all this stuff. So it's out there and fairly easy to find.
Fantastic, fantastic. I'll give one more question to you, and then we will wrap this up. And we do appreciate your time.
Sure.
So, if you're reimbursed by procedure, this is a general reimbursement kind of question. If you're reimbursed by procedure, then is it a false statement when an administrator tells you that the facility is not reimbursed for the use of something? If it is I'm going to read directly here. If it is a DRG payment, that means you are always reimbursed something. Is that correct?
That is correct. I think that what you have to understand is that for the most part, it doesn't matter how a hospital is getting reimbursed. They're always going to have a chart description master. They're always going to have pricing on a procedure basis. It doesn't matter if it's something we're providing or a surgery or things consumed. If we're charging, let's say we're charging, let me just throw out $145 out there for a breathing treatment, and we're getting reimbursed either by a DRG, which is a fixed payment for a diagnosis, or we're getting a capitated payment based on a per day or a per type of surgical procedure or something like that, or we could be getting reimbursed on a variety of programs that are discounts off charges. Insurance company looks at our charges, say, hey, well, I'll pay you charges less 40%. Maybe the hospital across the street charges a lot more, so they'll say, hey, I'll pay you charges less 60%. So that varies. But the bottom line, it's really, really tough for a manager to figure out how much of that $145 they're actually getting reimbursed. How much of that pie is actually theirs? If a DRG is $5,000, how much of that is covering the 10 breathing treatments at $1,400? And that's a question that I don't think we can get to. But this data at least provides us with understanding the patients that have respiratory type diseases, how much the hospital is getting paid. So it's really tough. It's really tough to figure out what percentage of your charges you're getting reimbursed when they are in a mix of capitated and highly discounted payments. And my advice to managers is continue, be engaged in setting your charges, but as you're managing your department, focus on cost and understanding if you're charging $145, that maybe what does that cost you, and that's what to focus in on your administrator, and how you can add value in this new era of healthcare reform, which is a totally different webcast.
You are absolutely right. Thank you very much, Rick. We really, really appreciate your time. This is a a whole new ball game for us, I think, and I think we're going to get a lot of questions from our patients and the public about this, and it's obviously important for the manager to understand this as well as the practitioner who has to answer the questions of the public. So thank you everyone for joining us today, and again, we will archive this and put it up on Webcast Central, so look for that in the next week or so. Have a great day.